Thank you so much for the lovely land acknowledgement. And one of the things I'm trying to do now is put different artwork up as I begin to explore and learn more from our First Nations communities around Canada. And I just really loved this picture, Growth from Love. And I think it speaks to this topic actually very well, because when we have a child that has a serious illness and as that child grows, there are a lot of challenges, but there are so many opportunities for growth and adaptation. And of course, love is what really helps support that journey. So quickly, we're going to review the definition of serious illness and the zones of, actually, I'm not going to talk too much about the zones of health, but I'm going to talk about the categories of children we see in pediatric palliative care that I think has a very good framework so that you as adult providers can kind of think about that. We're going to reflect on a parental journey for caring for a child with complex needs and the transition of care into adult service, discuss issues of inclusion, competencies, shared decision-making, and then how do we use this guide that we adapted for working with parents, and just talk a little bit about that. What I love about this group is you're all very aware of the Serious Illness Conversation Guide. That often is not true in our pediatric world. It's you know, we're slowly and surely trying to change that. But I love that this group has a lot of competency and understanding of how important this guide is. So how do we define serious illness? You know, this is how we sort of think about it. You know, it carries a high risk of death over the course of a year or within childhood is sort of how we sort of see it for our pediatric population. Has a strong negative impact on quality of life and functioning in life roles, and can be very highly burdensome to the person and the family. And again, from my pediatric palliative care lens, I'm thinking about, you know, the caregiving responsibility of parents, not only in childhood, but how that can extend beyond for many, many decades. So there's categories of children that we see, and it's a quadrant. We look at a quadrant. There's 4 quadrants that we look at in pediatric palliative care, and these quadrants or categories come from work that was done in England a long time ago, and I put the reference there if you want to learn more about it. But the first quadrant is this idea of life-threatening conditions for which curative treatment may be feasible but can fail. So you can imagine a childhood cancer, you get ALL, you get really good treatment in Canada, and it's cured. We don't tend to do a lot of pediatric palliative care for these children, but we may be involved in a consult here or there. I think when we think about it in adult terms, you know, we might have a child that had an osteosarcoma, was treated, was cured in childhood, or went into remission, and then comes into adult care and actually has another cancer or a treatment-based cancer. So you might see this quadrant 1, where you really will see this quadrant 1 child into adulthood are these palliative surgeries that we offer congenital hearts. So these babies are born with congenital heart problems. They get a quote unquote palliative surgery, including Glens or Fontans, or even potentially a transplant that they got at 5 years old. And we know those transplants only sort of last for 15 to 20 years. So you may also see this group of children in as they become adults in your care. So that's quadrant 1. Conditions where premature death is inevitable. So I often say to people, you know, do you think Canuck Place, do you think pediatric palliative care has any children with cystic fibrosis on it? And they'll be like, no, I don't think so. And I'll say, well, do we have a cure for cystic fibrosis? And they'll be like, no. Well, we don't have a cure, but we have all of these therapies that enhance their living, their quality, and their longevity, right? We've got better respiratory support. We've got better antibiotics or toiletries and things like that in terms of respiratory support. And so these people are living longer, and you're going to see some of these. And this also is true of muscular dystrophy. Duchenne's muscular dystrophy, when I started 100 years ago, many kids with young men would die of muscular dystrophy by the time they were 17. We rarely see a child die of muscular dystrophy in childhood now. but you will see them. They will have BiPAP on. They will have, you know, their life has been extended because some of the therapies we offer. We have not cured it, but that is another group you will see. Another category is the progressive conditions without curative treatments. And these are similar to quadrant 2, but they tend to be inborn or genetic mutations, single gene neurologic or multi-organ conditions that sort of peter along. They don't necessarily progress really quickly. I mean, obviously, if they progress really quickly, we'll see them in pediatric palliative care. But the ones that are, you know, like Dravet syndrome, they have lifelong seizures. They have developmental delays. And you're going to see those kids come into the adult system and will need care. And then lastly, and actually Dara and I had a conversation yesterday on email about this group. So this group, irreversible but non-progressive conditions. These are static brain injuries. Static brain injuries that leave the child or adult vulnerable to unpredictable life-threatening events like aspirations, contractures. So it's not that the condition is progressive, but because of the insult to the brain, we see it a lot in prematurity. So babies that are born young and have a hemorrhage, near drownings, failed suicide attempts, an injury has happened and it's left the body changed. And I think what Dara was saying to me on this email was, these are sometimes drug overdoses, right? That they've received naloxone, they've received recovery, but they've had a brain injury and has changed their ability to make decisions and to communicate and all sorts of things. So I spent quite a bit of time on that one, and I'm just wanting you to sort of think about this quadrant perspective, because it really does help us think, where is this child at, and why am I seeing them, and why should I have a serious illness conversation with them? Other considerations that are super important, young adults with medical complexity, is that you are probably, in many times, going to be talking to their parents, right? They're most often the decision makers, not always, sometimes ministry involvement, sometimes there's another guardian, but often the parents are the decision makers, and they may also be long-time intensive caregivers. And the reason I say this is that they are stressed and fatigued from the healthcare system. There was a study recently, I don't have it here, but they looked at the cortisol levels of mothers with children with complex needs, and they were predicting a 5-year less lifespan for that mother due to the stress that women are carrying. So these are stressed out people. Parents describe the transition to adult care as being difficult due to less coordinated and less resource systems. So you're going to have parents that feel like they fell off the edge. This is how they describe it. And the other thing that is so important is, because we in pediatric palliative care have this big sort of criteria, we see children for years and years and years. We do a lot of care coordination for our children on our program. And we call that palliative care. That is our standard of care for children who have life-threatening illness. We often, when we discharge someone from our palliative care program, it's not automatically that they would actually qualify for an adult palliative care service, right? So it's not like I can transition this kid to an adult palliative care service, because the criteria is much more narrow. I think 90, I don't know how Dr. Seiden would have of the stats, but about 80% of our children on our program don't have a do not resuscitate order. And we're still supporting palliative care, right? So it is a bit of a difference. And so families will sort of say, well, where's the Canuck place of adulthood? And there isn't one. There's an excellent article that was written by Jennifer Baumshaw, who is she's actually a mom of a complex child, and she wrote this great commentary called Clifford Bridge: Breaking Up with the Pediatric Healthcare System. And I put the reference in here, and I think it's a really good read. She uses modern language like being ghosted and it's not me, it's you kind of language through the article that's really, really good, and has lots of insights. So I want to talk a bit about healthcare decision-making in pediatrics. So this is where we sit in our pediatric palliative care model. And I just want to see if this is a fit for you guys when you think about adults who have cognitive disabilities and complex health concerns. So this is how we sit. Parents and caregivers are responsible for the welfare of their children, to support and guide children so they can understand to their ability and contribute to the decisions that involve their body, health, and care. Healthcare teams have the responsibility to seek the participation of children by respecting, to the extent possible, their developmental ability and express preferences. And children have the right to be supported in their understanding, to know what to expect and anticipate, to share their preferences and participate in decisions, and to be involved in important decisions in meaningful ways, even when they are not the primary decision maker. This is really important because there's a responsibility by healthcare to involve people with different levels of cognition, ability to make decisions, and all of that, to involve them deeply and to look for things that they can participate in their agency. And so they have agency around some of the things they can choose. I just took this picture off the internet. I don't know who this person is, but I love a visual because I think it's really helpful for us. So Dylan makes an appointment with your team or your clinic or whatever, and he's 20 years old with adrenal leukodystrophy. So adrenal leukodystrophy is a progressive condition. Okay, so you can be quite well, but it is going to get worse. You're going to lose, you're going to have more chances of respiratory events. Neurologically, you get worse. Your body systems fail over time. So important resources for Dylan, and this is beyond the presentation, but these all have, we can share these slides to you guys if you want. And maybe there's people on this talk that actually could do much better than me on this, social work and different people that are working with us all the time. But these are the resources around, breaks down what capacity and decision making is and sort of determines what types of legal supports and agreements someone needs. We have the healthcare consent, including how do we determine capacity, and then resource reviews on how healthcare decisions are made. So these are just resources for you guys to look into. But where do we start, right? Before we get all the documents and before we look at all of those things, and you have Dylan coming into your clinic, where do we start? So this is a good place to start, right? You see the parent, Dylan's in there with you. How does your family make decisions for Dylan's healthcare? Really getting a basis of how do they do it? Family-centered care means we have to figure out what the family does, not what we're assuming the family does or what we think the family should do in terms of their decision-making. Who provides Dylan his day-to-day care? That's enormous because those people may or may not be the decision makers, but they actually should have input somehow around what's happening. They might be your best source for actually finding out what his symptoms are. What do you feel Dylan understands about his condition or what's happening to his body, right? He might be nonverbal, but he actually can communicate yes, no, absolutely, preferences for things. So find out, what do you think he understands? And does Dylan prefer to be involved in meetings with his care, or does that bore or distress him? Some of these kids have been exposed over and over and over again to meetings about themselves, and it can be really boring, distressing, annoying, or they actually want to be more involved than they are. So just, again, opening up these questions to sort of figure out, how am I going to proceed with my assessment? I really like this visual, and I actually will use it with parents of kids, right? I might have a 12-year-old, I might have a 6-year-old. I might even have an 18-year-old that says, you know what, I'm leaving these decisions to my mom and dad. These are the 4 things I care about. But in terms of making decisions about my chemotherapy or timing, I don't want to know, right? So you can see that we have to consider this range of involvement, right? You might have someone that wants to choose and has agency with decisions and is empowered to do so, right? And if it's that, then you guys already know what to do. You do this all the time with your adults. But you might have someone that wants to share their views with parent or caregiver, but doesn't want to be involved in conversations, right? So have you talked to Dylan about some of the things he's worried about and what he's doing? And does he want to talk to me about it, or does he want you to share with me what's happening for him? It's not a do they get involved or they not get involved. It is a continuum of checking in with the family, checking in with the adult child, checking in to say what decisions do you have control over, and what are your choices, right? And we don't offer, just like we don't offer a 6-year-old choices about necessarily where they live, but we might let them choose what kind of bed works best for them, right? Is it a bunk bed or is it this kind of bed? So we have to think about if we're going to give someone a choice, are these choices that they can make? Do they actually have agency, and do they have control over that? So just looking at this continuum is really, really important. And we know that changes over time. I am not going to tell you about the benefits of serious illness conversations. Everybody who's done the workshop or taught the workshop has seen this. But I would say when you are first seeing a new patient that has just come into the adult system, it's a really good time to have a conversation, right? Transition points, getting to know you. I just want to learn about your family values. These are really important because, of course, we know all of these things, which you've seen this slide too, right? We want to have decisions made so that we can do our very best for our patients and families. So that's our guide. It's available easily through the center, and really just looks at asking questions to the parent, along with on the back of the slide, on the back of the guide, it actually helps ask questions to consider things like, what do you think your child understands? How much information do they want? How do they like to receive information, and from who? So there is a bit of guidance around that too. So if you're doing the guide, if you're going to have these conversations, just ensure the right decision makers and the caregivers are involved. Include adult child as they wish to be included, of course. Book more time to review the parent's understanding. They're going to have a lot of information to share with you. This is their time to share their course, which might be decades or at least many years, and the ups and downs. It also will give you an idea how many interventions they've had, and likely they've had many, including maybe multiple PICU stays. And this really allows you to understand what they understand, so that when you begin to share your information, you've got a basis for what they understand, and so you can either clarify, affirm, or help adjust their understanding of what's going on with their child. And of course, using the wish, worry, wonder, we love that. And I like this statement, hoping for the best, planning for the rest. Because we know prognostication in children and young adults with these complex medical conditions is really, really difficult to prognosticate. I mean, it's a little bit like your frail elderly, right? How do we predict? They could die tomorrow, or they might live another 3 years. This is the same sort of thing. So we're having these conversations while still hoping that he's going to make it to his brother's wedding next year. We're just having these conversations so that we can really plan for the just in case. So the question about critical experiences, we have found that with babies or with children or teenagers that have a disability, that have a different way or a less typical way of enjoying living and quality of life, we've changed our critical abilities to essential experiences or critical experiences. And it just lands way easier on families, because as soon as we say, what are some of the, your son's critical abilities that you can't imagine him living without, in the disability community, they can see that as sort of a little bit difficult, because you're like, abilities is like this: talking, eating, walking, skiing, like it's all of these things that able-bodied people do. But this question allows you to really hear the family talk about the experiences, like, I've had families say, when he's not able to orally eat or have taste anymore, that will be a huge experience for him because he loves his taste. Or if he can't go to his grandparents and stay overnight there, because the care gets too much, that's going to be a big deal, right? So this critical experiences really just broadens your perspective and allows the family to really think about those experiences and share those with you. Are there some things that he really enjoys now that you can't imagine him living without? What would 3 wishes you have for Dylan, and what do you think Dylan's 3 wishes are? If we thought about the next year, what would be 3 things that you would love to accomplish? And again, it gives you a flavor of what is so important to their essence of living, that helps you then manage, to go back to when he becomes critically ill. I remember you told me that if he wasn't able to be in his wheelchair anymore and be up and, be visiting, and that, being in bed all the time was not good quality of life, and I'm seeing these things. Remember how we talked about that? I'm wondering if we can talk more about that. It gives you again, a background. In terms of trade-offs, if your child had a setback, it's a lot softer, because I don't know, parents have just said that wording works better. If your child had a setback, what would be some of the things you think would be worth trialing to see if he gets better? And what are some of the things you feel he would not benefit from? And remember, be ready to face resistance about the trade-offs, right? When we see a child that we see as highly disabled or has a lot of physical problems and has a small sort of world because of their disabilities, we tend to just devalue that, right? But parents see a different perspective, and they've also seen very many times in pediatric care when they've gone to ICU and they've done BiPAP that their child got better, even when they've been told a whole bunch of times from a whole bunch of people that he shouldn't go to ICU. So whether they should go or not go is not, I try and really not hold that. What I want to hear from families is what they think is worthwhile and what their experience has been in the past. But I would say that if Dylan, in this case, goes back to ICU, adult ICU, to try BiPAP, and that's in his directives, that having endpoints for that family are really important. So to say, I hear that trialing BiPAP to see if he gets better, you don't want to intubate, I hear you, but trialing the BiPAP is really important because he's gotten better before. But I think it's really important that if he is not improving with the antibiotics or the supportive care for 3 or 4 days, we're going to talk again. So you're giving a warning shot that this is not the only conversation we have, that we're going to go back to you again and say, is this trade-off of being in ICU on BiPAP too much? And would this be an opportunity to bring in palliative care to support some symptoms if we were to reduce some of the interventions that aren't helping anymore? If we were to, de-escalate some of those interventions that he really hates. He hates having the mask on. So how do we help him, because he's not getting better? How do we help in shifting into perhaps end-of-life care? We're going to have breakout rooms, and again, I'll send out these slides to you if you want. But I think what we'll do for a minute, because I actually went really fast, and we have about 5 minutes to do. So I'd love to just hear questions. I just threw a whole bunch of stuff at you, and anything resonate, any questions, clarifications, arguments, I'm for it all. Bring it on. And feel free to unmute or put it in the chat, but unmuting, I love to hear your voice instead of my own, so.
Hi, my name's Ashley. I'm a palliative care doctor in Winnipeg that does mainly adult palliative care, but I also work at Cinnamont Center, where we have pediatric to adult with profound developmental delay. And I find it's an interesting sort of crossover. All of the concepts I find in theory, I'm like, yes, this would be a great way to have a conversation, but I find the majority of my adult patients, and I don't know if it's just the subset of people that I look after, I would say the majority of them are under public trustee. And so when it comes to conversations around what are their, like, it almost ends at me telling the public trustee what I feel this person's quality of life is, because I know them far better. And I do wonder now, with the push to having people with intellectual developmental delay in the community, that this PEDS population that we're seeing coming through and transitioning to adult will be far more involved with their families. But the current adult population right now, I'd say a majority of them aren't. And a majority of them, I don't know that the concept of them having like a terminal illness was how they were viewed as pediatric. So I feel like the group aging out now has had wonderful support from Peds Palliative, and they're sort of set up for these conversations. But the current sort of 50 to be honest, some of them 60, 70 years old, probably never would have thought that they would reach that age. Many of them, their parents have passed away, or they just don't have family involved. And that's where I find these conversations get really tricky. So I was just going to throw that out there for discussion.
Yeah, so there's a lot there. And I think first and foremost, our public system, and I know this is true in BC, that, I think the ministry and the people that are involved in caring for people are doing their best, but it's also very stretched, right? Like I know when we have to try and get the biomom and the industry and the people in the same room, it's really hard to do, but it's also worth the effort. So I think how do you one, get the people in around who caregivers, like people that provide, like bringing in people that are actually doing physical care is a really good way to, you might know them quite well, but there's people that are in those care homes that know them too differently than you. And so I think we have to broaden our perspective on who can support that patient's voice, who sees what experiences they have that are joyful or ones that aren't, things that are hard. So I think that's one thing. I think the other thing is what is the conversation, right? If a person with profound disabilities or intellectual disabilities isn't that sick, we're not doing advanced care planning in terms of medical directives. We're doing support in terms of improving quality of life, right? Finding out what's important and things like that. We have a zones of health framework that we look at, sort of how fragile a child is, that again leads us into, having more direct conversations about medical directives. Because if a kid is not going to tip over, if a kid's not super fragile, we're not asking parents, do you want to go to ICU or not? Right? We're not asking if they want to escalate care, because their child, it would be weird to just have a DNR, right? If they're not fragile. So I think we have to be thoughtful about where is this person in their trajectory of illness? How do we get the most information we can from the people that care deeply about this person? Of course, including their voice every single time that we can, but also who can help speak to the quality, us partially, but other people as well, and really documenting that as we go along. I would agree with you that sometimes it's us actually, to the trustee or to the ministry, we actually have to, in our role, say, I believe that intubating this patient would not be of benefit, that would not be in their best interest. This is a patient that loves to be in their group home, that they know their people, that they get very stressed if they're put into this situation. And the reality is he's had so many pneumonias that intubating him will probably not end in a good result. And I think if he got another pneumonia, we would want to really support intensive comfort care. So we actually have to, in our role sometimes, actually make those pretty directive statements. But again, we don't do that lightly. We do that with a bunch of background and a bunch of support from the people that know. Is that helpful? Anything I said in there, was that?
Well, yeah, and I find that, right, like that tends to be my approach, is the first half of the conversation is educating the public trustee about who this person is, because I see them weekly, and nurses input, and then the second part of the conversation is then me putting on my medical hat and being like, now this is what's acutely wrong with them. But I'm listening to the suggestions here going, oh, wouldn't it be lovely to be able to have these conversations with families who truly know this stuff? And unfortunately, right now, anyway, it seems like most of the conversations are with public trustees.
Yeah. And I think part of that is, you're right, parents can't stop being able to take care of their child, either because they're too old themselves, or unable to because of the physical needs and things like that. So yeah, it's super hard. And the other thing I think would be helpful in the system is if we had public trustees that had a lot of education already about it, but it feels like they cycle out. So you've done your work with one, and then it's the next week and you're like, where's so and so? And they're like, oh no, they quit. They're at a different job now. So I think I think that makes it hard for continuity in those, because it feels like the same person, you might have 6 different trustees cycle through. So other questions, and then I think we'll go into our breakout room, or any comments. Tara, go ahead.
Hi, Camara, I just had a question for you, I guess, around the language that you like to use, or the phrasing that you use to try to elicit some of those preferences and values from the child. And I wonder if there's an opportunity for that to carry over into this adult population that has intellectual or developmental disabilities and delays as well.
Yeah, I think I get a lot of cues from the parents and what language they use, and then I try and use that language too. So what are you understanding about your child's illness or your condition, and what's ahead, right? What's going on there? What does your child understand about what's happening? Or I'll say, I see that they've gone, they were walking and now they're needing more wheelchair time. And actually they're transitioning now into not being able to use their hands. What do you think your child understands about what's happening with their body? And again, that might be a 4-year-old, or that might be an 18-year-old. And when I use the word body, it reminds the parent, because sometimes parents are like, oh, they don't, I haven't told them anything about their muscular dystrophy. I don't want them to know, or whatever that might be. So I don't say their illness. I say what's happening in their body, or what changes are happening in their body, because it allows the parents to really think about the fact that, of course, the child is sensing something going on with their body. They might not know about the language of their cancer or their muscular dystrophy or whatever, their gene disorder. But what do you think your child understands, and what behaviors are you seeing as things change? So we're looking for adaptation to the illness. And, if the child is, what we see when a child isn't adapting is they don't eat as well, they don't sleep as well, they have other behaviors. So, what kind of things are you seeing in your child or your young adult, that would tell me that they're happy, that they're adjusting to their new care home, that they're feeling comfortable. And then how do, tell me what communication tools Dylan uses. Is it a thumbs up, thumbs down? Is it a communication board? And then once I learn that, I can say, Dylan, thumbs up for your new home, thumbs down. What do you think of this? Thumbs up, thumbs down. So you've got to learn from the caregivers how that person communicates. How do they tell you what they like and what they don't like? Oh, they have this elaborate communication board. You're like, okay, that's great. So it's really starting with the caregivers, learning from that, and then trial, being brave, and jumping into engaging with that young adult to say, I'm going to get to know you. You matter to me. I'm really seeing you, and I'm going to learn some ways to feel connected, so that when you come back to see me again, or I come in to see you in your care home, you're going to know that I see you. So I think we'll break into our rooms. There's a couple questions that maybe, Jacqueline, could you put in the chat? I want people to just talk with each other about this topic, and then we'll come back. I don't expect you to necessarily report back to it, but depending on who's in your group, just answering the questions that I think, there we are. Have you worked with complex young adults in the past? I'd just love to hear, you guys have a bit of discussion about some of the challenges or some of the things that you've learned. And then if wherever you work, think about how you can integrate some of these things in what kind of things would you integrate? If you were expected to see a new patient in your primary care office, or if you were going to a care home that that a young adult was placed, what would be some of the things that you might integrate into that? So can we break into say, what came up in the group, or something that an aha moment, or a takeaway? Just wondering if there's anything that someone wants to unmute and say. I'm seeing my old friend Jen Ham there, and I'm hoping she'll talk on this just so I can hear her voice. I put her on the spot totally, but she's not shy, so.
I am shy, but earth-shattering. We didn't also talk about the questions because we decided to just chat, but I really appreciate it. I appreciate getting to hear you again, Camara, and because I just became familiar with the serious illness conversation as a facilitator a year ago, and I hadn't even seen what the pediatric adaptation was to it, and I really loved the language that you shared today. That does kind of, I think, gentle down the language. Like I was imagining, using that language with anybody, really. I think
Do you want to be one of our facilitators? You're welcome to join us.
I would love to help out with anything. I did, yeah.
Okay, good.
Call me.
Any other comments before we do a closing? How are people feeling? I hope this was helpful. I ran through a lot of material, and I hope it was helpful, but I'm getting some nods, so that's good.
Right at the end of our group, I think we sort of were hitting our aha moment as our countdown for the breakout session ending. And so if I'm terming our aha moment incorrectly for our group, anyone else in our group can jump in. But I think where we were kind of the terms we were coming to is the experience of some of the group members in working in PEDS, where there is so much advocacy for trying the next thing, trying the intervention, things like that. And then for those of us with more experience in the adult world, where some of our experience is that it is someone with these maybe profound health impacts from childhood that are now developing everyday routine chronic illnesses like a cancer or something like that, trying to shift that focus of advocacy, because maybe advocating for that next intervention, that next thing that you always did in the PEDS world that offered quality of life, maybe a trach offered quality of life, maybe a feeding tube offered quality of life, it allowed them to get to adulthood because it was maybe a non-progressive illness or something like that. When these conversations around these interventions for a different type of illness in a patient with these underlying issues can get very tricky, because it's something you always advocated for because it would bring them quality of life. But now whatever illness is complicating their health further, is it better to reshift that focus, that your advocacy is better placed in deciding it's time to stop and deciding it's time to take a palliative approach. And it's tricky when the mindset has been so different through the PEDS world. and then plus just getting lost in the adult world, because that happens when you make that transition with that health history. But that was sort of, I think, where we were going with our group when our time ran out, but it was a good discussion.
Yeah, I thank you so much. I think that that's really good. I would say sort of two things around that trying to shift. And I think one is it's really hard. We get frustrated in pediatrics as well when we see that the parents' only focus is sustained living, despite how hard the life is of that child. So, but we have to stay with those conversations. So sometimes it feels like, oh, like this mom's not getting it, that's not congruent, what is going on? And I think who does these conversations best? It's palliative care, right? It is, we actually have the communication skills, the wish, worry, wonder, the shifting, the sticking with families that really are kind of stuck for whatever reason it is. So, I think the tolerance needs to be even more in this population, and which is why doing it within a team is really important, right? Bring in your buddy nurse or your buddy physician or your buddy social work, so you can do this and you can tag team and you can take breaks and you can enter it in different ways. So I think that's one of the things I'd really, really say is, you're going to go see this young adult and you're doing a home visit, and normally you don't have staff for two people to go, but some of these ones you might really have to advocate. It's going to be more important that two of us go so that we can support each other as we support this family. So that would be one of my things. I think the other thing, we do have pediatric palliative care clinicians scattered throughout the country now, and I would really have you lean into those. I'm listening to some stories on the island, Vancouver Island. We are so happy to pick up the phone and just talk through a case with you. We may not be involved clinically at all, but to say, hey, maybe some of these strategies would work, or please tell me what's going on there. Like even up to 25, 27 years old, the fact when a child has never left the care and been independent, then talking to peds people, that's their world, right? Their world is taking care of people who've never been totally independent. So if you have people on your caseload that have never been totally independent for whatever reason, then maybe talking to a peds friend, call up a peds friend and say, peds palliative care friend, and say, can you just walk me through this? What would be some of the things that might be helpful? Because we do know that parents or even providers will send the adult child back to emerge many times. And those conversations, it's not like, oh, you might even have a DNR, but they are used to going back and seeing if it's reversible. So those conversations happen so many times. And how do we keep doing that work and sustaining that relationship with caregivers, with a family that can be really stressful? So those would be my couple pieces of advice around phone a friend, take a friend, and keep practicing those, those reflections and those, communication skills that we know are just so essential in helping families shift to really living well as the young adult is dying. I'm going to stop there. I was right on time, 1:59.